Thank you. My name's Gemma Rumpleby. I'm a Service Improvement Manager from Hambleton, Richmondshire and Whitby CCG. I apologise to a few of you I think I have spoken to actually here today about discharge to assess, which I speak to a lot of people about quite a lot at the moment, so I promise I won't just talk about discharge to assess today. I am here with colleagues from North Yorkshire County Council and from our team at the CCG. And because, thanks to my school run, we've got the after lunch slot, because I've got to be at my child's primary school at 3:30, I hope that what we'll talk to you about is a little bit of variation from what we've heard from this morning. I think in Hambleton, Richmondshire and Whitby, we have taken a slightly different approach. One of the things that was really interesting earlier was we started to sort of gear into the conversation around frailty. For our patch, we've specifically been focusing on frailty and our wider community population, not specifically our care home population. So in some areas we're maybe at a different point than others, which I think today has been really interesting for us, hearing about particularly the trusted assessment work in care homes. For our locality, we're a very rural locality. Sorry, I don't normally need a microphone either. We're a very rural locality. We've got around 32 care and residential homes, but that means we've got real patches with absolutely no care or residential home available for our population. And that means for us, we work very closely with primary care in particular to have a very strong ethos around working together in a very integrated way. We did a community transformation consultation back in 2016, and it gave us two really clear messages. The first was care close to home, whether your home is in a care home environment or your home is in a house that you've lived in for 40 years. People want their care to wrap around them. And the second was that they don't want to have multiple assessments or multiple pathways. They want us to work as integrated locality teams. And a lot of our work that we've done since 2016 has been around working in an integrated locality team. We've also benefited from North Yorkshire County Council's investment in extra care housing facilities. We've got 5 extra care housing facilities across our patch, and within those extra care housing facilities, we have got NHS commissioned beds, which we call our step up, step down beds. That's really important for some of our areas where we don't have care or residential homes, but we do have extra care housing, and that allows us to have slightly more flexible pathways for our population. In terms of our providers, again, it's a really complicated picture, and I'm smiling at my South Tees colleagues as I say that, because we've got one main acute site, but we've also got a local acute site at the Friarage Hospital in Northallerton and community hospital settings across our piece. But across the whole of the North Yorkshire, we work with multiple providers. We have, as I said, got very positive relationships working with our GP practices, and that's been really fundamental for us, particularly as we move on the conversations around frailty. So I will hopefully get this the right way, because it seems to be, no, there you go. What we wanted to talk to you about as our key achievements is because I think we've taken a slightly different tack from other areas. One of our key achievements is around a piece of work that we initially piloted back in 2016 when we launched the Community Transformation Programme. And that's the Medicare, which is telemedicine in our care and residential settings. Now, I don't want to be a spokesperson for Medicare. I'm not a sales pitch for them. This was a challenge for us about how we put telemedicine into care and residential homes, because we knew it would help us overcome some of our challenges around rurality. We certainly did come up some of the challenges that have been mentioned today about not all our care and residential homes had good Wi-Fi. A lot of them had very little access to computers and technology. But what we did pilot back in 2016 was giving access via telemedicine to a digital nursing hub, so a 24-hour consultation within our care and residential home settings, and we also put it within our extra care settings as well. And it's been, for the commissioners in the room particularly, a challenging business case to keep this going in an area where this is additional spend to the CCG. But I'm delighted to say that last month we signed a 3-year contract with Medicare to deliver this. So we're no longer at the point where we're constantly doing the business case. We can now really continue to work this as part of our system, and particularly about part of our resilience to our care home sector. Basically, it is exactly what you would expect. It is a laptop within a care residential setting, and if a patient has a fall or a member of staff has a query about a patient, they can ring via telemedicine consultation to speak to somebody about their concerns, and they can, like a Skype facility, actually show the patient and do a one-to-one consultation. We're now at a point where we can reflect on what this has meant for us, and we have seen reduced care home admissions. I'd love to say our care home admissions have gone down. They haven't. But they have risen by around 1.7% against a national average of around 6 and 7%. And we can specifically see the difference between a home with telemedicine and without it. So we see that as a real success. Interestingly, the discussions around falls, our admissions due to falls in care homes has reduced. And that's because falls is particularly an area where if you use the telemedicine effectively, the care home staff can ring to say, what do we think is fall? And then it's not that member of staff's sole decision what to do. Actually, it's a clinical decision and it's a triage system that's in place to decide what's the best outcome for that person. One of the key successes is that 86% of the patients who are discussed on a call to a Medicare remain at home. They remain in their home environment. They don't leave site. And that's a real success and one of the main reasons we think the admissions has gone down. But it's really impacted our GP colleagues and the resources on primary care because a huge amount of calls go through telemedicine rather than go directly to GPs, particularly GP out of hours. And through the advice on the telemedicine service, we see a reduction in calls to GPs, which has been really positive. And I think picking up on one of the other key areas, which was not something we really expected from this service, was that it's really helped us increase our winter resilience. And I think when we reflect on that, what we've been able to do through having telemedicine in the care homes, if when we're at high pressure or when weather's really bad or there's an issue, and we're in the middle of winter at the moment, although it doesn't particularly feel like it too much, but when we are at high pressure, we've been able to get that message out to care homes and say, you're part of the system. And as part of the system, we need you to react. So please use the telemedicine service as much as you can. And because we need to try and reduce hospital admissions, the reaction's been really positive because I think it was almost out of a respect relationship there. We were saying to the care home, you're part of the system, and we're informing you that we're at high pressure. So if you have got a patient who needs admitting, they might not have as good a pathway as we would like. And interestingly, a lot of care homes have come back to us saying, this is our resource, these are our beds, and they've wanted to be part of that system conversation. Which I think when we're talking earlier about seeing them as part of the system and recognising what they the service they deliver, we've really seen that. And calls over winter, particularly when we put out those messages to the telemedicine service, have increased by 50%. So we've seen a direct response to that. The other key area where we have put an awful lot of investment, and I promised I wouldn't talk about it too much, is discharge to assess processes. Across Hambleton, Richmondshire and Whitby in the last 2 years, particularly, we've implemented a full discharge to assess pathway. So we're at a point now where if a patient goes into hospital, they will leave hospital via a trusted assessment process. The only exception to that is if the patient lives in a care home environment. So we've come at it from a different angle. We're now in a really good position that if a patient goes in and needs a social care package, they won't have a social care assessment on the ward. That would be done in their home environment if they were going back to their home. If a patient needs rehabilitation, they'll go to a step-down bed and have that for a period of time before they transition home. And if a patient has more complex needs, then we believe it's really important that they're assessed in an environment that reflects their long-term care needs, which isn't the acute. And we were in a position in 2017 when 46% of our DSTs were completed in acute settings, and we're now very proudly at 0, and we do not complete DST assessments in acute settings unless in very exceptional circumstances, of which I think there's probably been about 4 over 2 years. And those patients would go into a care home setting via a discharge to assess process, but we're not in the position at the moment where a care home wouldn't come in and still do their own individual assessment. And that's the learning I think we need to learn from today to really complete our discharge to assess process. We've got a joint provider event which North Yorkshire County Council are leading. And we've got another one planned in April, and we were just talking earlier that's really an opportunity for us to stretch our discharge to assess model to complete it using trusted assessment for care homes and residential homes as well. Okay. So, for those of you who have spoken to before, I do always like to try and go back to the so what. If it was my mum or I know, then what does all of this mean? And so we try and put a pathway together as a little bit of a challenge to us to say, actually, all these initiatives can be absolutely fantastic, but what do they mean as a patient? They need to work together to create a successful patient pathway. So when I looked at where we were with care homes, I've got an example here of a patient who has moderate dementia, she's got a care package in place, she's got a number of long-term conditions, and she collapses and is taken to one of our acute sites. Often what we know for our patients, as everybody here will know, is that in itself creates confusion, they present their needs differently, and the acute position here is that this patient needs a longer term assessment for her future care needs. The patient can't go home as they are. Now, because this patient was deemed to have some complex care needs, for us this patient would probably go into a spot purchase commission discharge to assess bed following a CHC checklist. That will be our pathway for this patient. The spot purchase arrangements would be made with the care home, but one of our key areas of success is we do that with North Yorkshire County Council. We, from any health bed in the care home, goes through the North Yorkshire County Council brokerage system, so that we've got one brokerage system now in place, which is a real area of progress for us and allows us to have a lot more consistency in terms of costings, and also just that relationship with our care sector. So they'd go into the care home via discharge to assess via North Yorkshire County Council's brokerage scheme, and at that point they'd then have a DST assessment for their long-term care needs. I think one of the main the points of this as well is that for patients who go in to care homes now, even if they weren't already in a care home environment, the fact that we've got telemedicine in there really does help our conversation with the care sector, because when they're accepting a patient who they don't know, are using discharge to assess, we can use the fact that we've tried to support their team and created a bit of extra resilience by the fact that they've got access to 24 hours consultation, and they've always got that triage point. I'm very much saying that if they went through telemedicine and the view was this patient needs to go back to the acute or needs a change, then there's no such thing as a failed discharge, but actually that decision wouldn't be theirs. It would be a clinical decision using a Medicare. So that's where we are at the moment. There's an awful lot of areas of opportunities. The other area for us is, of course, we have rolled out the Red Bags initiative. We are slightly behind some of the other people in this room in terms of that. It was rolled out at the beginning of December. So we are at the very early stages in terms of what that means and what the outcomes have been for patients. But we have already seen within our acute sector that they are being used effectively, which is really positive. So moving forward for us in terms of challenges and key priorities, we always feel the need to constantly stress our challenge of our large geography and rural sparsity. I think one of the points that was made earlier as well is we have multiple patient flow pathways. So for our patients, they can go to Darlington, they go to James Cook, they can go to Harrogate, they go to the Northallerton. And it's a real challenge to try and get the messages out. So whilst we can say, isn't it fantastic our care homes have a Medicare, the chance that a nurse on a ward in James Cook's knows what a Medicare is and knows that that can maybe change some of their outcomes in terms of identifying a discharge destination for that patient is a really significant one. And we are always looking at how we can improve that knowledge and understanding so that people really benefit from these initiatives, because there's always that danger that it will be purely communication which lets us down. We are looking at standardising the implementations of the frameworks, and as I said earlier, I think our key focus now is trusted assessment across the whole piece. We're really keen to share from today. I think we've made some real progress in terms of trusted assessment. We have trusted assessment referral processes for what we call Pathway 1 and Pathway 2, which is patients going home or into step-down beds, but we don't have them for patients going back to a care home environment yet, and that's our final step. So we'd really like to share where we are and also learn from others. And then we are looking at a sustainable plan for the introduction of the capacity tracker tool. Again, some of our homes are using it, but it's absolutely not consistent. And it's about how we roll that out, because it's an ask of them really in our area. So we need to understand what outcomes we're trying to achieve for the patients. And for us to be confident, we need to be able to go back to the pathway and be able to say, for Mrs. Wensley, what would it mean? What's the difference if we put that tool in place for her? And I think if we can confidently have that sort of conversation at that level, then everybody understands that. Okay. Any questions? And I will look at my table over there as well, particularly Angie from North Yorkshire, if there's anything around any of those initiatives.